99-point-something% reproducible. If I were to measure that scan, and Dr. Adams or another, or Dr. Obama or somebody else, or Dr. Sky would measure that same scan, we're going to get the exact same answer 99.9% of the time. Because the computer tells us that's a score of 82. And then I write down 82, and Dr. Obama writes down 82, and Dr. Sky writes down 82, and we all come up with the same number. So that's very helpful, because now the patient has a very specific number that they get, and they can follow over time. So this is one of the, probably, I'll say better, but one of the more robust studies that the National Institutes of Health did. At the initiation of this trial, they spent $63 million on this multi-ethnic study of atherosclerosis, population-based study, looking at 51% women, because that's the population in the US, looking at Hispanics, African Americans, whites, and Asians in a comprehensive way over many, many years. This was the first 3.5-year follow-up, and I'll show you more follow-up in just a moment. But very simply, a score of 0, virtually no events at all. And as they had more plaque, and again, the calcium score is just a volume, so the bigger the number, the more plaque you have in your coronaries. You have a little bit of plaque, you're 4 times more likely to have a heart attack or die. You have a lot of plaque, you're 10 times more likely to have a heart attack or die. You have a whole lot of plaque, you're 13 times, 14 times more likely to have a heart attack or die. So we can see over time that this is a very robust predictor of who's going to have a heart attack or not. If you want to compare this number, this is the number the ACC likes, the American College of Cardiology and the American Heart Association like the score of 100. It's a nice number because it's a round number, it's easy to remember, but they like this score because it's a 10 times of increased risk. If you compare that number, a 10-fold risk, to, let's say, that C-reactive protein is 1.17-fold increased risk, or a 17% increase in risk. This is a 1,000% increase in risk. So it's simple math, 80 times better than the C-reactive protein, if you want to look at another test that we commonly do for risk, on top of the risk calculator. This is after we had the risk calculator, we added the calcium score. So I looked at 10-year outcomes, because we always talk about what happens in the next 10 years, and all of our risk calculators are calibrated to 10 years. And I'll just blow up, these are the 4 ethnic groups, they all work the same. I'll just blow up one of them. You can see a score of 0, even out to 12 years, very, very low risk. This is 7.5% risk. This was in our threshold of treatment, 2013, so we did the study to show that if you had a score of 0, even out for 12 years, you don't hit a threshold where you should put a person on a cholesterol medication. But if you have some plaque, or a lot of plaque, or a whole lot of plaque, you have a much higher risk, and you exceed the threshold for treatment and should be treated. So, and all the ethnic groups, males and females, and younger and older patients, all play out the same. So the scan doesn't really care how old you are, it says how old your coronaries are. And that goes back to the 1600s. There was a scientist called Sydenham who said a man is as old as his coronaries. And we can basically tell you how old are your coronaries. And it should work for a woman as well, although the Middle Ages might have been a little more misogynistic. But so we can tell exactly how old somebody is, or their arteries are, compared to how many years they've lived on this earth. Because obviously things don't always progress at the same rate. But I think one of the most, this is just another study, a long-term follow-up. Again, the same thing. For a heart attack, it predicts stroke very robustly, predicts major adverse events, it predicts death. And a high score, bad outcomes quite frequently. Lower score, this is from the military, Walter Reed, from one of the Army cohorts. Lower score predicts events. 0 score, excellent. This is out to 17, 18-year follow-up. Excellent survival with almost no events for heart attacks, for strokes, for death, or for major adverse clinical events, like all of them combined. So it really works robustly to tell us who to treat and who not to treat. A score of 0, this is one study in 7,000 patients with a score of 0 followed for over a decade. And again, whether they had a family history or not, if their score was 0, they had excellent survival. So it definitely is a stronger predictor than knowing if your family members have it. Because you don't know, right? My dad had heart disease at a younger age, but he weighed twice what I did. Breakfast was always bacon and eggs every day. Smoked 4 packs of cigarettes, thanks to getting them for free while he was in the Korean War. They gave him free cigarettes for being in the military, and he got hooked, and he smoked 4 packs a day. And he had early heart disease. He developed diabetes because he was overweight. Do I have that same risk? Well, I have premature heart disease in my family, but my score at age 40 was 0. So I didn't have any evidence of early plaque, and at age 50 was 0. So I don't have, it wasn't a genetic thing, it was my dad's lifestyle was different than mine, and probably explained why he had early heart disease. So it totally clarified for me, what does a family history mean? Because for me, I don't consider myself to have a predisposition to early heart disease, as long as I don't follow my dad's footsteps and smoke a lot and eat poorly and not exercise and gain a lot of weight. So I think that's really important. This is probably a little complicated, but I just wanted to show you that.
I'm sorry to interrupt you, but you and I share family history, and I don't want people to think that it's all lifestyle that controls that 0 score. Because in my family, our scores range from less than 100 to over 1,000, and good lifestyle.
Yeah, no, I mean, so yeah, the flip side can also occur where it is truly family history, where you have early heart disease in your family, and you do have the gene. The problem is we don't know what the gene is yet, so we can't test for the gene. We have to test for the, what we call, instead of the genotype, we test for the phenotype. Does it exist? And my phenotype is negative, and your family's phenotype is positive, so you have real family history, and I have fake family history. But there's no way that even a great doctor can elicit which one of our family histories is real or not, because we can't test for the gene to know if I got the gene or not. We just have to see what happens, and that's not a good way to go. Let's see what happens and see, because what happens is, in a third of people, is you die. Oh, I guess you had the gene, because you died, right? Then it's probably late to start all those great preventive therapies that we can afford patients. Another trial I've been interested in trying to do is see if we can throw some cholesterol pill in their mouth while we're doing CPR to see if we can start lowering the cholesterol while we're trying to save their life. But too little, too late, right? So we want to make sure that we identify these people early and clarify what is family history. And I think this is one of the best uses of this test, is to clarify, is there really a family history, or is it a difference in generations and lifestyle? And our generations are different. The older generations smoked a lot, right? Our generation smoked less, and our kids maybe vape more, but not smoke more. But we'll see what happens there. But we're going to have to see how that translates. So this is an important graph, and I apologize, it's a little bit busy, but it's really important. This is true outcome data. And I just want you to look at 0 risk factors. So most doctors would say, you know what, you have 0 risk factors, don't worry about heart disease. Right? That would just be a normal, natural extension of what we know, because risk factors kind of tell us who's at risk. These people have no risk factors at all, and yet if they had a positive calcium score, they actually had a pretty elevated event rate compared to people with no risk factors and a score of 0. So going to green is a score above 100, and yellow is a score of 0. Conversely, these people would be told, look, you've got every risk factor there is. You definitely have heart disease. We got to really work on this. And if they had a score of 0, they had a very, very low event rate. And if they had a high score, the combination of a lot of risk factors and a lot of calcium made them really high risk. But the better predictor between the two was how much calcium they had. Score of 0, low risk across the board. High calcium score, high risk across the board. How much calcium they had was a better predictor than what risk factors they had, or how many risk factors they had. So this really does override, if you will, what we know about risk factors. Because risk factors just means if I took a population of people with high blood pressure, how many would have a stroke, or how many would have a heart attack, or how many would have heart failure. And that's not the individual, that's a group of patients. This is the individual. This is personalized medicine. This is their own arteries. Do my arteries show that I'm at risk? and I can say yes or no getting a scan. So another one, same thing. This is just looking at long-term risk. This even looks interesting at dying of cancer. And dying of cancer is worse if you have a lot of coronary calcium. And there might be some interaction there, cancer causing inflammation, causing atherosclerosis, some long-term interaction of those people with cancer. But those patients who had high calcium scores were 5 times more likely to die of cancer. And if you look at all-cause mortality, this is dramatic, going from a 1.6 rate per thousand, so that's 0.16%, a low number, to a big number for just dying. 10 times the risk if you had a high calcium score. So it really does predict all types of death, heart attacks, including strokes, cancer, everything pooled together. And this is really one of the best studies that we have, just showing that all types of death gets worse if you have a lot of coronary calcium.
So I emailed you with great worry reading this slide about whether or not this is age adjusted, and you said it isn't. And so what you see in your data, right, is that most people with the scores over 1,000, unfortunately not all, are really old,
Yeah,
right?
yeah.
And so I just wonder if maybe you could write up that age distribution as a future.
Sure, we can look at this, but I mean, even the older people then who had a score above 1,000, they're right. There could be some age bias here, but generally, once you do age adjust this, the statistics still hold. The math and this chart is not age adjusted, but the paper was multivariate adjusted, including age and other risk factors.
I am worried that what I just said gives people the wrong impression that it's just for the old, because Steve Sidney's paper that was presented here last month indicates that for those age 32 to 46 who have a score over 100, 22.5% of them will be dead in 12 years, which is shocking. That group to me wakes me up at night.
Yeah, that's the Cardiology study, very important trial. Another NIH trial, National Institute of Health trial, that showed that even the younger individuals with high scores more likely to die over the next decade or so of follow-up. So the other reassuring thing about a score of 0, because people are worried about, well, should I really withhold therapy, right? Because we're talking about maybe people even with diabetes, certainly people with high cholesterol, certainly people with risk factors for heart disease, and then you're not putting them on some therapies. But look at what happens. This is really what happened, and these are all the negative risk factors. In other words, no coronary calcium, no carotid plaque in ultrasound, no low C-reactive protein, low cholesterol, low Lp(a), and you want to be down here at no events, and the only thing that really gets you to very, very low events is a score of 0. So the low score really drives down your risk better than any other predictor that we know of. It really does push you to the lowest possible risk. So the person who has the lowest risk of any way we know of stratifying risk is a score of 0. Again, going back to the power of 0. What about adherence? This is right where the slide of the calcium picture was, right before this slide. But the Eisner randomized control trial said, well, will the scan really motivate people to do the right thing? This is 4-year follow-up, so we're not talking about New Year's resolutions that might last 4 weeks or even 4 months. They get the traditional risk. This is a randomized. This was a randomized, controlled, prospective study, randomized to either getting a nurse and a nurse practitioner to talk to them about their risk factors, or adding in the same type of intervention and getting risk factor consultation about what they should do, and now adding in a calcium score to further refine that information. And this is what happened. If you look at the patients who had no scan at all, they did have a positive outcome. Their LDL was a little bit lower. They were in the trial. They got told, oh, your LDL's high, you should probably be on treatment, or your blood pressure's high, you should be on treatment. And they did do some of the right things. But look at those patients with a positive calcium score, especially the highest risk, the people with the highest scores, huge improvements, triple the cholesterol reduction, double the blood pressure reduction. And these are really meaningful changes. In a population of people, if you were to lower the blood pressure by an additional 4 millimeters of mercury, you prevent a lot of strokes and heart attacks. More people exercise, and again, this was 4 years later. More people exercise, more people used cholesterol medicine, more people used blood pressure therapy, more people were on an aspirin tablet, and more people were actually taking their cholesterol medicine or staying with it. And again, 4-year follow-up. So really impactful down the road to show people that they have disease versus not knowing.
Yeah, this is very powerful. So how many patients were in the study, and could you...
So about 2,100, so about 1,000 in each arm.
And was this just a standard population? It said middle-aged?
Yes, this was the enrollment. I didn't go through all that, but they should have. This was a middle-aged population, 45 to 79. They were asymptomatic, so they couldn't have had heart disease going in. They were just a screening population, or the typical population that we want to know, are they at risk? So this is the age of atherosclerosis, 40s to 70s, without known coronary disease or stroke, and then followed for 4 years.
And do you know anything about the ethnic breakdown?
I think this was done at Cedars-Sinai. I'm guessing it was largely white. Just knowing
their
their
results to the physicians.
Yeah, they pass on the results both to the patient, there's a result to the patient and to the physician. So both, so that's important, yeah. So this was, the patient also found out, they got to see their scan, whether or not they had plaque or not. When they saw the plaque, they behaved better. These are asymptomatic, middle-aged patients, which is really our target for screening. Who do you want to screen? Middle-aged people, right? Because they're very old, we know they're going to have some plaque, and they're very young, we know they're going to be healthy. It's the people in the middle that have the untoward events and die young, or younger than they should. So, what about heart failure? So there's been a few studies that looked at calcium scoring, and calcium scoring actually predicts heart failure events. Maybe because it shows the atherosclerosis, and some of those people have heart attacks and develop heart failure, but calcium scoring is actually a moderate predictor of heart failure by itself. And more importantly, if somebody has heart failure, calcium scoring is excellent at identifying, is it from coronary disease or is it from some other cause? And that's also very, very helpful and impactful to help us as clinicians treat them appropriately. I can decide, okay, you have a dilated cardiomyopathy, it's not from heart attacks, I need to work on blood pressure and alcohol and other risk factors that might cause the heart to dilate and get weak. Or you have a lot of coronary calcium, the sensitivity is 97 to 99%. You have a lot of calcium, you've had heart attacks or coronary artery disease as your treatment, as your problem. I need to go down the road of fixing the arteries. So it really helps us identify risk among the doctors. It does predict, and both calcium at baseline and progression of calcium predicts new heart failure as well. So this was a study that we published from the multi-ethnic study of atherosclerosis. Over time, the increase in calcium score was an independent predictor of who's going to develop heart failure. So it not only tells us who's going to have a heart attack or stroke, but who's going to have heart failure as well. So again, just expanding the use of this to help us with all of coronary or cardiovascular disease, not just the coronaries. Can we treat somebody with a positive calcium score? Can we lower their risk? We can't lower the calcium score, but we can definitely lower their risk. And this was a relatively small trial, only about 1,000 patients, 1,005 patients randomized they had a positive calcium score. They were again asymptomatic, so similar to that last trial, they were asymptomatic men and women, middle-aged, ages 50 to 70. And middle age changes as I get older. Middle age gets older and older. So, but this is still middle age for today. So we're middle aged here, 50 to 70 years old, and they had a high calcium score based on their age and gender. So they're at increased risk. And then we randomized them to either atorvastatin or placebo and followed them for 4 years. And if you put them on a simple, not even a high dose statin, which is what they should have gotten, probably in today's world. This was done in the late 90s, around the year 2000 it finished, maybe 2001, early in our cholesterol algorithms of care. 20 milligrams of atorvastatin lowered heart attacks by 30% and lowered heart attacks and death by 44%. If they had a higher score, the number was even more robust. It lowered overall clinical events by 42%, a huge number. And the absolute benefit was very large. So the number needed to treat, 16 people treated for four years, and one of them doesn't have a heart attack or die at the end of 4 years. The most cost-effective delivery of statins in asymptomatic persons ever published. There's no study that beats a number needed to treat of 16. There's no algorithm of care that's ever come close to this. It's better than having diabetes. It's better than having multiple risk factors for heart disease. The ASCOT trial studied hypertension plus 3 risk factors, and the number needed to treat, you have to treat 93 people to prevent one event. Here we had to treat 16 people. So having the actual disease was the best predictor of improving their outcomes with a statin. And obviously, we can do a whole lot better than atorvastatin 20 these days. That's not even a higher dose of atorvastatin itself, and there's more potent drugs out there today. The Eisner study, and I apologize, this was out of order by a slide, but the Eisner study looked at cost, and I thought this was very interesting because everybody argues that we're going to drive up healthcare costs by identifying all of this disease. But in reality, it was cost savings, or at least cost neutral, for the overall population. Because so many people had scores of 0 that those patients had 37% less procedures. If you had a score of 0, oh, you have no plaque. I'm not going to say, oh, you know what you need? A nuclear test. Or you know what you need? A treadmill. I would say, you know what you need? Eat right and worry about something else in your for the next 5 years. Or worry about heart and worry about other things, but don't worry too much about your heart. They don't need cholesterol medicine, and that saved 26% of overall costs in the study. So we actually saved money by getting a scan. So it doesn't increase healthcare costs, it decreases healthcare costs again, because 50% or more of patients have scores of 0. 0 is so prevalent that it drives down healthcare costs. So this is another proof of the cost effectiveness algorithm. This looked at cost effectiveness, that calcium score can accurately reclassify patients into low or high risk. So those patients who have the highest risk can most benefit from aggressive preventive strategies. Cost effectiveness of calcium is robust. So again, we can get them on the right statins, we can get them on the right aspirin, and promote more adherence. They've got to take the pill to get the benefit, and calcium helps us do that.
Sorry to interrupt.
That's right, please.
So what did they use as the cost in the cost effectiveness study?
Yeah, so this one was done with generic statins, right? Because this is 2015, this model.
Excuse me, I meant the cost of the scan.
Oh, the scan? Oh, yeah, so the cost of the scan varies. In this paper, they use $200.
The $200
Yeah.
for the cost effectiveness.
Yeah, for this paper, but they have tables where it varies based on the cost. And obviously, as the scan gets more expensive, you lose more cost effectiveness. If you make the scan cheaper, you save more and more money. And I think it was not only cost effective, but cost savings when the scan was about $80. When the scan's about $80, you actually save healthcare dollars overall in the model. In the first paper, in the Eisner study, it saved money, and the cost, I think, was $200. In the MESA paper, I think it was like $80 was where it saved money. You actually started saving healthcare dollars by offering the test. So we're in that range. Remember, we consider cost effectiveness up to $50,000 a year, because that's how much we value in our models, how much we value human life, that your life is worth 50 grand per year. So anything cheaper than $50,000 per year is cost effective. But cost savings means that you actually save money by doing the test, and that's between $80 and $200, depending on how you model. There's a lot of modeling, obviously. How much does that heart attack cost? How much are they really going to get charged for that bypass surgery or heart failure episode? So all of those are models. Again, number needed to treat. If you took patients who were recommended by the C-reactive protein, you have to treat 500 patients to prevent one cardiovascular event if their score is 0. You have to treat 24 people to prevent one cardiovascular event if they have a positive calcium score. So we can go from treating 550 down to treating 24. And that's where a lot of the cost savings comes in, even in the era of generic statins, where the cost of the drug is not expensive, but there's still cost associated. What about aspirin? I think this is going to be the most important use of calcium scoring moving forward, is trying to help us as clinicians. It's a very complicated and confusing landscape of who deserves an aspirin tablet. It used to be a no-brainer, give it to every middle-aged person. And now it's become fairly complicated. And part of it is because the studies were done very poorly, and I don't want to go into that, but a lot of the aspirin studies that are done in the contemporary time are just poorly done, because so many people can just get aspirin, right? They're not on aspirin, and they're randomized to no aspirin, but they take Alka-Seltzer every few days because they get GI upset. Well, that's aspirin, so they're taking aspirin. So now they're in the wrong group. Or they go to CVS and their knee hurts, so they grab some aspirin, because aspirin is up everywhere. You don't need a prescription. So the studies couldn't control for all of that contamination in the trials. Nonetheless, this can really help us. Whether you're low risk or high risk, this is the number needed to harm with aspirin. It doesn't matter what your calcium score is. To have a major bleed in your stomach, that's the number, about 470 people. If you've got a score of 0 and you're low risk, you have to treat over 2,000 people to prevent one event with an aspirin tablet. So you're gonna have to treat 5 times as many people then you're going to have a major bleed. That's a bad deal. To prevent one heart attack, but to cause 5 hospitalizations for GI bleeding, not a great trade-off. So we don't want to treat patients with scores of 0. Even if they're high risk by their risk calculator, it's a bad deal, about 2 to 1. Two times as many bad events will occur to prevent every one good event. What about at this end, calcium score of 100? Well, it doesn't matter if you're low or high risk. You've got the plaque, you've got the disease, you're at risk. And it's about 5 to 1 in favor of calcium scoring. In other words, if you put them on aspirin, in favor of aspirin, you put them on aspirin, it only takes about 100 people to stop an event. It takes 500 people to cause an event. So you're going to prevent 5 heart attacks or strokes for every 1 GI bleed you're going to cause. So it's 5 to 1 in favor of treatment at the far right, and it's 5 to 1 against treatment at the far left. And this helps clinicians a lot, right? Positive calcium score, you've got atherosclerosis, you benefit from being on an aspirin, right? Let's assume aspirin is free. It's still, a GI bleed is an expensive endpoint. So we know that calcium improves delivery of both statins and I would say and aspirin, at least in my practice, because we match risk of having a heart attack or stroke with intensity of therapy. 50% or more patients will have scores of 0, and it improves compliance, and that's really very important. So I'll leave you with some ideas of where it might be the most useful for primary prevention. This is from the Society of Cardiovascular CT, not my own list, but these are where the testing may really stand out to help us as clinicians identify patients who would benefit. So it's that intermediate risk group that I've been talking about, and this is where the American College of Cardiology and American Heart Association says to focus. 5 to 20% risk. Well, that's 50% of the population, so that's a big number of people. Family histories we talked about, the difference between Hattie's family history and my family history becomes crystal clear with a calcium score. People who are reluctant to take a statin who need it. So I take some of my patients who I know need a cholesterol pill. I'm like, look, you have every risk factor, you need it. And they're like, well, I don't want to take it. I heard that it can cause liver problems or memory problems or diabetes, and I'm not going to take that pill. So I say, okay, we'll get a scan. And if you're right, I'm going to leave you alone for the next 5 years because you have a score of 0 and you don't need the statin. And if I'm right and you've got plaque, I want you to try to go on the statin and see how you tolerate it. And that's really helpful. Same thing with statin intolerant. A lot of patients who say, I can't take a statin, really don't have the classic symptoms or the classic intolerance that we know of, and they can try it again if they really need it. Sometimes, all of a sudden, they're tolerant